patient comes to us from different physicians or cardiologists or from other centers. Once they arrive to us and we realize heart transplant is for them, we see to do it that first we stabilize this patient. And most of these patients do not want admission to the hospital, and they refuse the admission because we realize that whatever injections, whatever management, whatever treatment we do, these patients come back to the same symptoms, same problem, and now they are so fed up of getting admitted to the hospital again and again, over and over, that they would like to be at home, just they want to come for a medicine. And then we selected some medicines which we can give intravenously at home, and these patients were so comfortable, and we started this home monitoring at their home and reaching to them. And after 3 or 4 days, these patients come to us, get this medicine refilled, and they go back. Or sometimes we send our REACH program goes to their home and help them out about this medicine. Then we also have a preventive care cardiac rehabilitation exercising training program, and we start this exercise training program even before operation, whenever they are waiting for a transplant. And that is very essential, because after that, after the operation, sometimes it is very, very difficult to teach them on these issues. We have a very extensive team of which includes a cardiac surgeon, cardiologists, intensivists, anesthetists, and psychologists, and infection doctor, and the administration, and the social worker, who all of them as a compiled group will advise and interrogate with the patients for what the patient and the family is going to go through. Because it is not an operation, I believe, that patient comes to the hospital, I give them an appointment, you get admitted, and next day I will operate you, and then in 4 days or 5 days you are home. This is not a kind of the play. This is sometimes the patient has to wait, and that psychological trauma is tremendous and phenomenal. Many times I have to call these patients for a transplant, and then transplant gets cancelled because the donor heart is not good, or whatever organizational problems or strategic problems or logistic problems, and then they become, the whole family has to come in and come out and come in and go out. And that is very unpredictable, and that we all explain to these patients so they get psychologically motivated and come out of this problem much easily. So if we go to the next slide, what is the need of an hour? Why you need that hour? And then the end-stage heart failure treatment is largely unsegmented market. It was uncharted water, and there is no treatment for it. As we realize, there are 4 medicines which does not improve the power of the heart, which is the main problem. The muscle power of the heart is not improved by any of these medicines, and the medicines what we give, or any hospital or any doctor gives to this patient, is to support their lungs, their kidney, and the liver, that they don't get damaged because of the congestion, because the bad effect of the heart, heart does not come on them. And strategically, it is expansion of the scope by diversification, without unsettling our basic cardiac surgery, like bypass operations and valve operations. And by focusing on a regular organ donation campaigns, we ensure that the organs to cater to the terminal heart failure patients require heart transplant. Now, there are 2 issues which we are tackling here: the management of the recipients, keeping them in stable condition so that they do not require, which I explained to you in the first slide, and it is a multi-factorial or multifaceted program. Like all of the doctors, they put their involvement, and everybody has his own job and they do it. So there is no interference of anybody. And this is to avoid these patients going into mechanical support or a mechanical assist device or a ventilator. Because when that is required, the cost phenomenally goes up, the chance of failure of the heart transplant phenomenally goes up. And that is very, very important to keep them in a right position. And we have to wait for these organs until the proper donor is available to them. And the gap is been filled by these heart failure clinics that help them a lot. The donor is, again, we realize that the donation rate in India, as we come from south to north, goes on decreasing. And in Maharashtra, it was 0.05 per million. I'll come to that slide afterwards also. Now, in last 1 year, since we are going to the interiors, to the schools, to the colleges, to the clubs and Rotary clubs and Lions clubs, and to all the community, as well as the doctor level, to educate them about what is brain death is, what is brain donor is, and who can be a brain donor. The brain death donor, so that they can donate their organs of heart, liver, and kidney, and then to educate that family, to consent them for organ donation. It was a big task, but now it is very, very fruitful and gratifying to know that it is going on. So when we started in 2015, there was 0.05 per million, the donation rate of the organs. Now it is 0.5 per million. And now when it was not known or never heard of organ donation in the newspaper or all, the media has taken it tremendously, phenomenally in last 1 year, that everybody know from auto rickshaw to the prime minister, everybody is talking about the organ donation. And that is very, very essential, very, very helpful, and I'm very thankful for the media for doing it, advertising it, or giving the articles in the newspaper which will reach to the common man. The next slide is strategic tools. What we use. We use the various analytical tools, whether this program will be successful or not. And to work around this, we have to work around political, economic, social, technological, environmental analysis of all these. Because when we started this program, we had in our head how it will go about, who will be required. Then, because I was not aware I will require green corridor even the first transplant which has to come from the out of the city, and it was very uncertain. I have never thought of it, but then we had thought of it almost 6-7 months before, and we have our team and our administrators have gone to meet the commissioners. They have helped us so much so that they gave us one point contact if such things happen. They wanted to know what the green corridor from us it means to them, and they are very, very happy, and they are doing it extremely religiously, happily, and they are very proud of it, that they are doing it for such a cause, and that has helped us. And thank to the public of Mumbai who stand sometimes in the hours together when there is a green corridor. So that green corridor also has helped. For that we did require a political thing. The economic and social sector, that is the same thing, that Mumbai is helping us, the people are helping us by technology. For the technological things, we are challenging, we are going into it and helping out, so that this traffic withhold may not happen, and we can use sometimes the drone technology. That work is going on, and we are also looking at the economics of it to bring down the cost as much as possible. Thank you very much for the government of Maharashtra who have reduced some cost of the medicines which are essential, necessary as immunosuppression drugs, and to help these recipients to work on that. We also are working and looking at, as a donor family, we directly cannot help them out financially because it's a donation, and it is illegal or unlawful to go and help them financially or otherwise, because it acts in a conflict of interest. But if there are NGOs and government organizations who can directly or indirectly support the families of the donors, that will motivate them to donate the organs, like looking after their health, looking after their education, some kind of a thing, which even if I want to do it, I cannot do it directly. Otherwise, the scams and scandals and other things will happen in this part of this also. There are a lot of the social awareness was at the same time happening, and at the same time the scams were going on. But remember that the scams are possible when it is a live donation. And in live donation, people will change their God also. Forget about for money, they will give their organ. It is so easy to do it in this country. But if it comes to the cadaver donation, the chances of that will be remotely possible. It is impossible almost. And I must point out at this stage that 85 to 90% of the transplants in Western countries is on cadaver donation, while 10 to 15% are on live donors. Whether it's a kidney, liver, whatever. Heart cannot be on a live donor, it has to be a cadaver donor, but I'm talking of the live donor programs of transplants. In India, 85 to 90% are live donors and only 10 to 15% on cadaver. And I think at some stage, not in my generation, but in next generation, it should change. And the movement of change is happening. And again, I point out here, it's all because of the excellent media who has helped us in this program. The service area competitor analysis like infrastructure and customer base and cost effectiveness, we all have analyzed it. And the most important infrastructure problem we get is for the airlifting of the organs, or transporting the organ from one place to another place, or transporting the patient donor from one place to the another place is sometimes getting difficult. But these are teething problems for each program. There are some kind of problems, and I'm sure we will come across it as we focus on our strength and our limitations. We will go to the next slide, and in the next slide, I think how is a no, I think I jumped the slides here. How did we make it sustainable? And our aim was not to do one transplant and advertise ourselves or be a mover of this program and just go to sleep and do nothing about it further. But it was we have to make it sustainable, and the sustainability is the main key for working on it and researching it and analyzing it properly from the day one. Almost we were talking about it and thinking about it before this first transplant happened, about for a year and a half. We all for making it sustainable, we of course got advantage. We were the first movers of this program. We developed the new market and defined care and quality about it. And we are training now the people and the nurses and the intensivists and the other team members who are paramedical people, even for donor side and even for the recipient side. And they will probably in future will continue this happening in other centers as well. So we developed a smooth process flow as it makes the system independent and can become more efficient as well. The penetration at community level and creating niche segment for ourselves that has helped us in making the program sustainable. And our administrative support is phenomenal, and that is why probably the sustainability from terms of finances and getting the right people and good people and sustaining them and retaining them has helped this program at various levels. Also, the campaigning which has happened for donor or to donors has helped us tremendously to sustain the organs. Without the donors, this program will never ever sustain, because there are no live donors in this. You understand? We all dependent on heart transplants, are all dependent on cadaver transplants. And I really salute to the donors, or the families of the donors. And we here at Fortis Hospital also have made a wall of honor or wall of tribute to help them out. There are hospitals where you have got a wall of the names of the people who donate the money. We have got a name of the patients who have donated their organs, and that makes them very proud, and that also makes helps us to get the donors in a continuity. If we look at when we started from nothing, from zero, we have done almost now 24 transplants in 1 year. Till today, we have done 29 transplants with 1 heart lung transplant in it. And this would not have been possible if we would not have got the donors. So, even approximately 2 donors, that is 15 in 15 days, we are getting 1 donor from we started this program, and that is excellent. That is phenomenal. In Tamil Nadu or in Kerala or in Hyderabad, they are getting almost 1 in 7 days to 8 days. So they are little ahead of us, not little, quite ahead of, but they are doing the transplant for since last 10 years or more than 10 years according to. So the sustainability has helped us because of the various people, various donors, various recipients, and administrative support. The specialization and in this service area, our routine work has not stopped. Our routine work has not gone down. Many times we have to postpone the operations. Many times we have to postpone our elective cases when the transplant comes, because transplant takes almost 2 days and 1 night easily. And when we are working on it, our patients need postponement, but they never ever creep. They are more very happy. And in fact, our routine work has increased. If it has not, I'm not talking about slowing down also because of the transplant. It has increased further, and patients have shown more trust in the hospital and the management and the doctors as well because of these heart transplant programs, which has created a new horizon, new specialization as a multidisciplinary inputs. And everybody is getting trained. Everybody is getting confident that they can tackle the worst scenario, the serious patients and difficult patients. The cost differentiation is the initial goal is to make the service sustainable, and that is why we are starting from the low cost. But however, the other costs which are required for airlifting the organs and the logistic reasons, we just cannot cut down on them, and we don't have a control on them. And I appeal here again, and as we have already appealed in different newspapers and otherwise, that government should help us in getting this aviation department charges little less if there is an organ donor, or availability of the aircrafts possible. Will, of course, the recipient, the hospital will pay for it, but otherwise this program will be impossible to sustain if the recipient list goes on increasing and the awareness program has to be increasing. So from villages, from other cities, from outside cities, the donors will keep coming, and if we cannot do this program, then the organs will go into the wastage in the dustbin again. The constant updating of the clinical teams and the various technological advantages will continue. The training for ECMOs, training for the LVADs, and we have this. We have started these clubs in our every 15 days, or once in a 15 days, or once in a 3 weeks. We have this program that somebody comes with the new ideas, new technologies, the new things, and new journals and articles, and the new invention somewhere has happened, and to implement or not. And we discuss at everybody of us will discuss, all the recipients, all the donors, what are the problems happened in the previous heart, which should not be repeated again. But there is no repetition, and always there is a new program, new problem, and there is a new solution with every transplant which has been happened. We have the group as an experience of the Fortis group for the transplant is phenomenal, and from north to south and from east to west. Among all the Fortis hospitals, where the Fortis Mumbai is the only hospital who is doing heart, lung, kidney, and liver, all organs, all cadaveric organs, important cadaveric organs under one roof. It's the only Fortis hospital who is doing all the organs transplants in his Fortis Mumbai. And I thank for the team and the administration. When we look at the SWOT analysis and looking at the strength, the core competency of the group of the young, dynamic, and motivated people coming together for a cause and passionately. We did not have to tell that you do this or designate the work or allocate the work. It came from their own that, okay, I'll do this, I will do this, I will do this. And it happened automatically. And that is very essential to get this young group of dynamic people. They are not, I would say, aggressive, but they will work at any time, any day, any cost, whatever. But this is for the passion of developing this program. But the results, when they are good and gratifying, the smile on their face is the one which kills all the money or amount or anything. They have got a clinical skill set, and the teams motivated enough to take any challenges, the learning new skills. And when the call comes for a donor, from the donor, the whole team is on alert, and everybody is like jumping to do something or the other. And this energetic team has motivated, and that is the biggest strength behind this. Apart from the admission support, which is very valuable, and tirelessly given reasonable autonomy in deciding the cost, and had faith in the whole clinical decision making. And that has tremendously helped us. At the middle of the night, I just cannot call 10 people in the administration and find out. So we have one point contact, and that faith, the willingness to help from administration is what is the strength of this, one of the strengths of these programs, I would say. The weaknesses, yes, there are lack of organs, as all of us know, and we are debating and discussing on it and how to improve it, and we are working on that. So non-adoption of the resumed consent, that also the problem. The need for donation after the cardiac death, that is the weakness, because it is not yet passed through the assembly or passed by the law in our country. It is happening in some few countries in the world, but if it happens here also, then the chances of getting more organs is possible. The lack of clinical people skilled in organ preservation. As we go to the interiors, we are losing these organs because in the small nursing homes or the interiors, like in beyond Thane and all, or Kalyan and all, there are no proper nursing homes or hospitals which will recognize the brain death, recognize the urgency of keeping them in a good condition. The many times I am asked the question that if I am a pledge for organs and if I have a donor card, will doctors look after me? Of course, they will look after me. Remember that when you are declared brain dead, then you by neurosurgeon and neurologists, the intensivists, nurses, other doctors do not look after you because you are going to die, because you are already dead. You are brain dead, isn't already dead. So nobody looks after the dead patients or take care of them. And when we have decided to donate the organs, they have to take utmost care. And sometimes the investigations and the medicines we have to give is very, very costly. But that care is taken by the organ who will be taken by the recipient. And that should not be worry about it. But it is very important to understand that there is a lack of skilled doctors and the staff in peripheries who will look after this organ preservation. There is average infrastructure difficulties I am talking about you. That is one of the weakness is the airlifting of the organs, and we will continue to talk about it. And I think the one day the solution will be there. The affordability and the need insurance support and revised government schemes and policies is also important. The opportunities, the creation of the newer market of ventricular assist devices, ventricular assist devices will be big coming way. Although it is costly, the cost of that is also coming down, and affordability also will be coming up. And those who cannot wait for the organ, who are not getting the organ, or those patients who are not good candidates for the heart transplant, then in those patients, I think the left ventricular assist device is very, very useful to them, and the results of the transplant and this LVAD is absolutely the same except for the cost. But on long-term running cost of this LVAD is less than the transplant cost. The creation of awareness of the organ donation is happening. We are doing it, and many of us are doing it, and I'm very thankful to all of them who are initiating this program in various levels and in the society or in the community. The government interference in organ donation and campaigns and help of them in reducing the cost for the immunosuppression has really helped in these programs. The threats, I don't think there are threats for this program, but we can, on theoretical basis and on a paper where we can say it is unregulated market. Well, it will be a regulated market. I wouldn't say it is a market because after all it's a donation and the need of an hour and the patient who is dying, and we are taking an organ from patient who is dying to giving to that organ to a patient who is dying, and there is no other scope, there is no other medicine, there is no other operation for these patients. Please try to understand this. This is not a market. This is just a science, and there is remain as a science until something else which comes up, which will compete with them at a low cost and better benefits. Then, when we are taking this organ, we are not taking from the live patient, live person. Remember, we are taking from one who is dying, and there is no need of these organs to that other human being. But there is a need of an organ to keep him alive in this other human beings. The shortcuts to success, there are many. The malpractices can happen. But these are all theoretical threats, I would say. It happens, it is beyond anybody's control. The bottom line is to focus on the strength and a constant review on a core competency and creating the finger edge on it comes to a clinical skill. The self-beliefs and deliverables are very, very essential and important in this. If we can't do, if I cannot do anything, I cannot do anything. And that transparency with the relatives, with the patient, with the transplant, we are keeping at the moment. Looking at what is the problem rather than who is the problem, that is how we are working. And that has really helped us to go up and above anything. Because we can never change who is the problem. Even if you replace me, there will be somebody who is there. But if we change what is the problem, then the things happen smoothly and settle down very easily. The patience to wait is very essential, and the mental strength to get up after repeatedly falling. Like I tell the horse riding is something we always fall on the horse. We tell what is the next thing, we jump on the horse again, and that helps these young people to keep them motivated. Thank you very much.
First question is, are we doing enough in order to receive cadaver donations?
Yes. we are doing enough to receive cadaver donations. Means if there is, we have never said no to any call for who wish to donate the organs. It is the right of every resident to say that I would like to donate the organs. They should not think I want to donate only heart. Can I donate my heart? Can I donate my lung? Can I donate my skin? Can I donate? They don't have to think. They have to say, I would like to donate the organs. Let the doctor decide. Is that skin good? Is that eyes good? Is that heart good? Is that lung good? That is the job of a doctor. He will never ever take the organ which is not in a good condition because of age, because of the disease of that deceased person, and take it and give it to somebody who requires it. If it is only in good condition, we will take it. So the job of the family is to say yes to the organ donation, that's all. And if we are doing it enough to receive organ donation, yes, we have started now doing all the transplants: kidney transplant, heart transplant, lung transplant, liver transplant from the cadaver. There should not be a need of a live person to go and give one of his kidney or half of his liver.
Next question. What happens if rejection occurs after the transplantation?
Death. Death. If the kidney gets rejected, the patient can go on dialysis again. But if the liver or heart get rejected, either we have to put another liver or another heart, or death.
Next question. What tests are necessary to determine a person is a heart transplantation?
Yes. We do various tests in our heart failure clinic. The most important test is that whether it is heart is so weak that it cannot be recovered again, and is it got beyond the possibility of preserving it by medicines or other way. That is echocardiography tells us. Then we do other tests, what called right heart catheter, to find out if because of the heart the lungs are also affected. There is no fault of lungs, but the heart is damaged so much that it starts affecting the lungs. And if lungs are affected, and if I change only heart, then the new heart cannot sustain the pressure of the lungs and it fails. And you understand? So the new heart will not able to eject, pump the blood to the lungs because the lung pressure has gone up. Lungs are already damaged. So in those patients, heart and lung both are required, not only heart. So we do that test to confirm that his new heart will tolerate the pressure in the lungs. So that is right heart catheter. The third test what we do important is that panel of reactive antibodies. What is panel of reactive antibodies? It is the antibodies in that patient, in the recipient, which will determine if I put any organ in his body, whether it's a heart, whether kidney, whether liver, whether lung, doesn't matter. If I put any new organ in his body, what are the chances that his body will reject or refuse this organ? If it is high, then we say no to the transplant. Then left ventricular assist device or a mechanical assist device are the better in these patients. Try to understand. Can we do transplant? I can do transplant. What are the chance it will benefit him? Very, very less. Because the chance that it will be rejected is more than 50%. That is what the panel of reactive antibodies in him has said. So if it is between 25 and 50%, then we have to give more immunosuppression. Then we find out what is the age of the patient, are there any other medical problems in this, what are the chances that he will get infection, because immunosuppressions can give severe infection. And if the immunosuppression dose I have to give on higher side, then chance that he will get infection and he will die because of that early are very high. So we have to balance this, and then whether you should get a heart transplant done or you should go for a mechanical assist device. And if it is less than 25%, the chance that they will the rejection rate is very less. I'm not saying zero. I'm not saying it is, so it is 0 to 25%. In those cases, the immunosuppression can be used to prevent the rejection rate. The rejection rate is highest in first year, but it is never zero for rest of your life. That is called chronic rejection. There is something called acute rejection, hyperacute rejection, acute rejection in 1 year, and chronic rejection after 1 year. So any day, any time, this rejection. There is something different with the liver transplants, and kidney transplants and heart transplant can have a rejection any time of your life. The liver transplants usually they survive 1 year. The chance of them living for easily after that is very, very high. So it depends on each organ also. Is that answers your question?
Next question from Shalini.
Yes.
What is the major difference in heart attack? Her second question is, can a person survive after having a cardiac arrest?
The difference between heart failure and heart attack is very, very important and essential to understand. The heart attack is because of the stoppage of blood supply to some part of your heart muscle. That is ischemic heart disease or coronary artery disease. So when I have a heart attack, the muscle of my heart, somewhere, little bit of muscle, is like if you cut one branch of a tree, but the tree stands. You understand? But tree is there. But one branch of the tree has gone, it has fallen. So if one branch of the artery get blocked, 100%, that part of the heart muscle die. That is called heart attack. When the heart muscle die, we cannot make it alive. When somebody die, it will not work. So it stops, that particular part of the heart muscle stops pumping the blood. And if it is death, then he will not get chest pain also. In heart failure, there is no chest pain. In heart attack, there is a chest pain. If there are multiple heart attacks, that large part of the heart muscle is damaged, then the pumping of the heart goes down. And when the pumping of the heart muscle goes down, that is called heart failure. So the pumping of the heart muscle can go down because of various reasons. Because of multiple heart attacks, one, can be because of the valvular problem, can be because of viral infection of the myocardium or the muscle, can be because of dilated cardiomyopathy, because of the familial reasons or genetic reasons, can be because of congenital problems, can be because of diabetes, can be because of severe high blood pressure. There are different causes of heart failure. Heart failure means the pumping of the heart is bad. Heart attack means the blood supply of that particular part of the heart muscle is bad. And if it is a huge or large heart attack that affects the main branch or blood vessel of your heart, supplying the blood supply to that area, then like you are cutting the tree at the bottom of it, the whole tree will fall off. So when sometimes somebody has got a massive heart attack, that he was standing talking and suddenly he collapses, that means is a major origin of the blood vessel is 100% blocked for whatever reason. So that is the difference between heart attack and heart failure. And what was the next question you said was, can somebody survive after a cardiac arrest? Yes, somebody can survive the cardiac arrest. And when the resuscitation is got in time properly, the cause of that cardiac arrest is reversed. Yes, the patient can be alive, patient can sustain after that. Yes, it is possible.
Next question from Preeti. What is the cost of heart transplantation in India?
In India, the cost of the heart transplantation is very difficult for me to tell. From Delhi to from Karnataka, from Kanyakumari, and from Assam to Mumbai, it is totally different. But there are certain places who are trying to get down the cost tremendously. The heart transplant per se is it can happen in 10 to 12 lakhs rupees. But the logistics of airlifting this is extremely variable, and they are asking any amount of money from us, and of course the recipient has to pay. We share that, the hospital administration shares and try to cover it up from somewhere or the other way, from one pocket to another pocket, but there is no control on this aviation. I'm not saying they should give us free treatment like abroad, I'm not saying that, I'm asking anything free lunch or anything for them, but making the things more difficult, and the prices goes up, and if I want a aircraft at the middle of the night at 1 o'clock, because the donor is not willing to wait, and they want a body back before 4 o'clock in the morning. What should I do? I cannot wait till the morning because the Jet Airways or the Air India flight is at 8 o'clock. I cannot wait because the donor wants the body by 4 o'clock. So I need to get the airlifting at around 2 o'clock midnight. And then the cost goes up phenomenally. From Pune to here, they ask me for 7 lakhs rupees, 6 lakhs rupees, anything. And if it is a daytime and they know I can come by the airlines or something, they will come down to 2 lakhs rupees also. So that variation is impossible for me to tell what will be the cost of it. But if I neglect that, and if I get enough number of donors from Mumbai itself, and I do not have to go out of Mumbai, then the cost will come down around 15 lakhs. Every city has a different market. Every city has a different prices. Even a blood bank will give a blood in Tamil Nadu at 1,200 rupees. In Mumbai, it is 3,000 rupees. If I go to Pune, it is 1,500 rupees or 1,200 rupees. Same blood bank, same blood bottle. Same blood bottle from the blood bank. So cost of it is everywhere is different.
Next question from Ishan. How long does it take for a person to recover from a heart transplant or surgery?
Now we have done 28 transplants in 1 year and a few months, 2 months. And the average is from, I would say average, the range is from say 10 days to 12 days to a month or 1.5 months. So we can take the average of around 2 to 3 weeks.